factors, factor V latent mutation, prothrombin mutation, high D-dimer levels, and non-O type blood groups. The second classification is acquired risk factors, which includes age, history of previous venous thrombotic event, obesity, cancer, recent surgery, hormone therapy, and use of oral contraceptives. Last category is the triggered factors, which include high altitude hypoxia, immobility, trauma, fractures, surgery, long travels, and varicose veins. These risk factors lead to a hypercoagulable state or endothelial damage causing the thrombus formation. This is a diagram that represents how various causes cause thrombosis, through which mechanism. Risk assessment based on the probable cause of DVT. The strong risk is associated with fractures of the pelvis, hip and long bones of the lower limbs, hip and knee arthroplasty, any general major surgery, a major trauma or a spinal cord injury. Moderate risk of DVT is associated with arthroscopic knee surgery, central venous lines, congestive heart failure, estrogen therapy, malignancies, paralytic stroke, pregnancy and postpartum, and genetic factors. Weak risk is associated with a prolonged bed rest of more than 3 days, age of the patient, laparoscopic surgery, obesity, and varicose veins. The risk assessment is done based on the modified Wells score, which includes clinical signs and symptoms of DVT, any alternate diagnosis other than PE if it is likely, heart rate of more than 100 beats per minute, immobilization of more than 3 days, or a major surgery in the last 4 weeks, previous history of DVT or pulmonary embolism, episodes of, and if the score is less than 2, the patient is at low risk of pulmonary embolism. A score of 2 to 6, the risk is moderate, and a score greater than 6, the patient is at high risk of strategies to prevent DVT. In hospital patients, the strategies include early mobilization after surgery, guarded compression stockings and DVT pumps for bedridden patients, anticoagulation therapy for DVT prophylaxis in high-risk patients. In OPD management, in patients who have long sitting hours or are traveling on long flights, it is suggested that the patient should get up and walk around every 1 to 2 hours, and while sitting, the patient should exercise their legs by 3 basic exercises. First being raising the heel and lowering it while the toes are fixed on the floor. The second being the reverse of the first one. You fix the heel and you move the toes up and down. And the third being tightening and releasing the calf muscles. It is suggested that such patients should wear loose fitting clothes. Weight management and avoiding sedentary lifestyle is an important measurement. DVT prophylaxis is moderate risk and high risk to DVT. The low risk patients include young patients with no risk factors for DVT. There is no need for prophylaxis in such patients. Moderate risk patients include patients with at least one risk factor. Pharmacological prophylaxis is preferred with or without mechanical prophylaxis. And high risk patients include patients with multiple risk factors. In this, pharmacological prophylaxis is recommended along with mechanical prophylaxis. The pharmacological agents for DVT prophylaxis include low molecular weight heparin, including enoxaparin and dalteparin, unfractionated heparin, fondaparinux, direct oral anticoagulants, and warfarin or acetron. The low molecular weight heparin and fondaparinux are preferred over unfractionated heparin due to the requirement of less intensive monitoring of the blood parameters. This will be discussed later. The mechanical agents include pneumatic compression, guarded compression stockings, and venous foot pumps. Contraindications to pharmacological DVT prophylaxis are active bleeding or recent bleeding or high risk of bleeding, patients with coagulopathy, patients planned for a surgical procedure within the next 6 to 12 hours, severe thrombocytopenia, and bleeding disorders. Contraindications to mechanical prophylaxis include limb ischemia due to peripheral vascular disease and skin breakdown. Moving on to DVT prophylaxis in pregnancy. The highest incidence of DVT is seen in third trimester of pregnancy and in the postpartum period. Pharmacological prophylaxis is considered in patients with following risk factors: a history of prior DVT event, hospitalization for an acute illness or planned for cesarean delivery, and presence of an inherited thrombophilia. The duration of prophylactic therapy in pregnancy. Antepartum prophylaxis is continued throughout the pregnancy. In patients, inpatient form of prophylaxis is continued until the patient is ambulatory, provided there is no need for outpatient prophylaxis. The optimal duration of outpatient prophylaxis remains unknown. The American College of Chest Physicians suggests at least 6 weeks postpartum with a longer duration of up to 3 months in those at a greater risk. Moving on to the treatment of venous thromboembolism. So depending on the Wells score, if the risk of DVT is low, a D-dimer test is performed. If it is negative, we can discharge the patient. If the D-dimer is positive or the Wells score suggests high risk for DVT, we are supposed to perform an ultrasound for DVT scan. If it is negative, the scan is repeated after 6 to 8 days. If positive, the patient is started on treatment for DVT. Anticoagulation therapy is the cornerstone for treatment. It is associated with both substantial risk and benefit. Optimal balance between reduction in the recurrent VTE episodes and risk of potential life-threatening bleeding has to be obtained. It is suggested to immediately start the anticoagulation therapy as delays can cause potentially life-threatening embolization events. Treatment options include low molecular weight heparin, enoxaparin. Studies and ASH guidelines have suggested to calculate the exact weight-based dose instead of a set dose. The dose is 1 mg per kg subcutaneous twice daily. In patients with eGFR of less than 30, the dose is half. Deltaparin, the dose is 200 international units per kg daily. A maximum dose can be given up to 18,000 international units per day. Renal dose adjustment is done on the basis of anti-factor Xa levels. Fondaparinux is given as a once daily dose based on the patient's weight. Weight less than 50 kg, the dose is 5 mg per day. 50 to 100 kg, 7.5 mg per day. And greater than 100 kg, 10 mg per day. Fondaparinux is contraindicated in renal impairment. The benefit of these drugs over unfractionated heparin is less intensive monitoring. Unfractionated heparin, it is given as an IV infusion. 60 international units per kg is given as an IV bolus, followed by 18 international units per kg per hour. A repeated APTT monitoring is required every 6 hours. The target APTT is 60 to 85 seconds. The advantage of this is that there is no renal dose adjustment required. Oral anticoagulants, warfarin, the starting dose is 2 to 5 mg orally, once daily. It is started on day 1 to 2 of parenteral anticoagulation. Daily INR monitoring is required for dose adjustment. Parenteral therapy is discontinued once the target INR is maintained for more than 24 hours. The target INR in patients on warfarin is 2 to 3. Usual maintenance dose is 2 to 10 mg per day. Lower doses are recommended in patients with renal impairment. Direct oral anticoagulants. These include factor Xa inhibitors that are rivaroxaban and apixaban and direct thrombin inhibitors that is dabigatran. Fixed dosing and without intensive anticoagulation monitoring. The dose of rivaroxaban in acute DVT is 15 mg twice daily for 21 days, followed by 20 mg once daily. The dose of apixaban is 10 mg twice daily for 7 days, followed by 5 mg twice daily. Dabigatran is given along with parenteral therapy and is started after 5 days of parenteral therapy at a dose of 150 mg twice daily. Dose adjustment is required in end-stage renal disease. The duration of therapy. In cases of VTE, due to transient risk factor, the duration of therapy is 3 months. First episode of unprovoked VTE, 3 to 6 months of treatment is required. A second episode of unprovoked VTE, lifelong treatment is required. And lifelong treatment will also be required in case of any inherited cause leading to DVT. Risk-benefit ratio of extended anticoagulation should be regularly reassessed. Interventions in VTE. First is IVC filters. The indications include active bleeding with anticoagulation and recurrent VTE despite adequate anticoagulation. Complications are cable thrombosis leading to severe edema in bilateral lower limb and filter fractures. Fibrinolysis. It is indicated in massive pulmonary embolism. The drug of choice is recombinant tissue plasminogen factor. The dose is 100 mg IV over 2 hours. Pulmonary embolectomy. It reduces the risk of bleeding associated with fibrinolysis. A catheter-directed embolectomy is a possible alternate to an open surgical embolectomy. Thank you.
So, we'll take questions after the session. May I call first speaker, Dr. Kunal Sharma.